Well, it's a pleasure for me to be here and talk about the future. That is my way of looking at hypertension management, comparing with where we have been and where we are and where we will be. So I want to address several issues that I really are for practice within the next decade. And then perhaps as the questions come later, there will be issues of more pressing current concern. Okay. Disclosures. I don't have any conflict of interest issues that I'm aware of, and I will not be discussing off-label use of any drugs unless there are specific questions. Generally, I'll use generic names for all medications, and because of some of the issues, the main problem will be doses that are not ordinarily recognized as within the normal dose range when we get to that point in the talk. Now, there is no question but that the progress in prevention of cardiovascular disease during the 20th century and extending well into the early part of the 21st is because of the treatment, detection, and the management and treatment and control of hypertension. This process began in the 1970s with a recognition based upon superb clinical trials that lowering blood pressure with medication prevented stroke, prevented heart disease, myocardial infarction, and heart failure, prevented progression of renal disease in many situations. And so the issue was, can it be done? Can this a population-wide strategy of controlling blood pressure by prescribing pills in doctors' offices, can it work? And it worked in the trials, but did it work in the population at large? That's the crucial issue. This is probably the most recent report documenting control of hypertension and use of anti-hypertensive drugs in the population. This was published 2 years ago. Nothing since has really changed the picture with one big exception. Now look at the top lines here. This is whether or not the patient is receiving any anti-hypertensive drugs, and this compares overall with diabetic hypertensive patients. And you can see that we are well above the 50% range for medication, and for the higher risk group of diabetic hypertensives, the frequency is increasing to where we can begin to think maybe close to 100% of the diabetic hypertensive population will, within a decade or two, be effectively treated with drugs. Now, control of hypertension is slightly different, and you might wonder, why is there this apparent discrepancy here? And it's because those who write guidelines were premature. This is the line to look at. This indicates the control of hypertension in the United States using the now consensus view of 140/90 for all patients, not just for non-diabetic hypertensive patients. Now, when this was written, some guidelines were published stating, on the basis of opinion rather than data, that the control level for diabetic hypertensive should be lower, should be less than 130/80. As a result, you have this peculiar discrepancy here. This is the control level for diabetic hypertensives using the number that was chosen by a committee of experts. When the committee of experts looked at the data, they changed their minds, and this is true of several guidelines throughout the world, not just the United States, and that because of their views and the data, this is now acceptable for control of all hypertensives, whether they have diabetes or not. And if those of you who want the details on this, I refer you to the Accord trial, which I'm not going to go into in detail for, but establishing that this is really the most appropriate number for the time being. Now, why aren't we perfect? Perfect means that every hypertensive who has hypertension needs to be controlled, and those who don't have hypertension need to have the correct diagnosis. So what is the solution to that problem? Should we have false positives? Should we allow false positives for hypertension to be treated with drugs they don't need? And so these are what I view as the barriers for optimal care of hypertension going forward. One is we need more blood pressures. To treat a patient on the basis of a single office blood pressure by a hurried clinician and an impatient patient is probably not good medicine. We need enough blood pressures to know what is the blood pressure of the patient, not in the office, but in their life. We need to coordinate blood pressure control with overall risk evaluation for future cardiovascular disease, so that this is gaining ground, and you'll hear much more from others about this particular aspect, so I'm not going to belabor it. We need better use of existing anti-hypertensive drug therapy. We have every mechanism for drug treatment is now well defined. There is not going to be any new antihypertensive drug approved in this country for the foreseeable future, and I'm not sure there's need for such. So we need to better use what we already have. We have a large armamentarium, and we should be using it effectively. And then there are those who don't appear to respond to well-meant therapy. How do we confront the resistant hypertensive patient? What strategies can we use to improve control in those who seem to be above the line? And then this is where I think the future really is emerging fairly quickly, is moving from the clinic to the home. Self-care for hypertension has already being studied in England and some parts of this country, meaning that the patient measures their blood pressure at home, out of the office, that they adjust medication within limits, and with supervision of you and hopefully me as well, to assure that their blood pressure, when we don't see them, is at a level that we want. So this is, I think these are the challenges for the next few decades. Now, out-of-office blood pressure, I want to spend a little time on this because it has become so important. Clinic blood pressures may be inaccurate for many reasons. The devices may be inaccurate. The hearing of the listener may not be so good. And it's too small a sample. 1 or 2 blood pressures is just not enough to know what the patient's diagnosis is and certainly how they're responding to treatment. So we have 2 strategies that are well studied in the literature: ambulatory blood pressure monitoring, and this is now the gold standard for trials of treatment of hypertension, and is increasing in its role in other settings as well. Or blood pressure measured at home by the patient with an accurate device in a protocol that can be used by us. And this is supported, particularly the home blood pressure strategy is supported by our friendly computers and the internet. In other words, the network of information systems that allow us to go from home to provider and back and forth. Okay, here's an example. Here's a young man who is wearing a cuff attached to, you can't see it here, a battery pack a little bigger than your cell phone, and it is recording his blood pressure as he goes through his ordinary day working. As it turns out, he was working in a hospital. So this can be recorded round the clock and gives us this profile. These are hourly average blood pressures during the day, during various activities, not exercise, because that isn't accurate, so we exclude the exercise periods, during time at home, sleep, and then back up to his next day's activity. This has specific definitions. The average day pressure is shown here, the nighttime sleep blood pressure is shown here, and then the morning surge, because most patients have an increase in blood pressure to their previous daytime level. Now, we can do a lot with the numbers. We can average the pressure over 24 hours. We can look at the blood pressure during sleep, compare the two, look at the surge in blood pressure in the morning. Some people go way up and then come back down. So we get a lot of information in using this technique. Now, this is home blood pressure. It looks a little the same, but it's quite different. This is with a device the patient takes home. This is happens to be an Omron device with memory. It was one of the first that we could use, and records blood pressure with each measurement. This is this patient in the office with the same device. office pressure. The young woman went home. She was working through the week, but these are her home pressures. And as you can see, they are all normal, falling from an office measurement of, I think, 160/95 to an average at home of 126/82. She does not need antihypertensive medication. She should stay out of a doctor's office. That's her big risk. And as this happened some years ago, and I'd say it's close to 15 or so, to maybe even 20, and the patient is happy and healthy, and I do have some follow-up, although she's moved away, but as far as I know, she's perfectly well. Now, this is a home blood pressure device. This person who I don't know is sitting at home in his apartment, and he's measuring his pressure with a device, but the device is linked to the equivalent of a cell phone. This is a cell transmitter, this can now be done with your iPhone. And so this sends the blood pressures to his provider. And this is sort of the overall picture of the system. This is, the name of this particular system is a Stabilograph system. It's used in Germany. There have been publications of its use, its validation, etc. But this is the concept. Patient measures their pressure at home. They send it through their phone to a computer, which sends the data on to the provider, who can look at the blood pressure pattern and return information to the patient about, you're doing fine, don't change your medication, or you're not quite where I want you to be, so please increase the dose of medication or take another medication that is needed. Now, as I mentioned, the self-care aspect of this is that this could be the patient as well, who has a prescription pad or has a plan with a pharmacy under the supervision of one of us that says, pressure's not what it ought to be. The message comes back, increase the dose of your, let's say, amlodipine from 5 to 10 milligrams, and then let us know how you're doing. So the self-care model, combined with telemetry and home blood pressure monitoring, is, if you'll permit me a speculation, the hypertension care of the future. Now, where are we? We're monitoring this process. You will be, and I'd like to think that in a few years I will be as well. And so I think this is a crucial element in looking forward. Now, this has led to, this combination of things has led to some new definitions that you may be familiar with, but I want to be sure that we're on the same page, as it were. What is white coat hypertension? White coat hypertension is real. It means very simply that the clinic pressure or office pressure is above the goal, 140/90, and at home or during the day it is much, much lower. It's normal. Below 135 and 85 is the criteria that most who write in this field agree on. And so what to do about these individuals? Well, apart from keeping them out of the office, is anxiety, stress, etc. related to this? And the answer is still somewhat unclear. But in general, the prognosis of those with white coat hypertension is the same as those who have normal blood pressure. It's a very slow rate of progression to cardiovascular disease. Studies vary a little bit, but nonetheless, white coat hypertension is far better to have than its opposite, masked hypertension. This means, and this is, as you might expect, is a kind of difficult situation. What if the pressure in the office is actually normal, or close to normal, high normal, but when the patient is at home or at work, in a 40-hour work week, let's say, much higher? And there are such patients. The risk of these for cardiovascular disease in this masked group is almost the same as sustained hypertension. These are the ones we like to find and treat. These are the ones we'd like to define and watch. So we have these techniques. This sort of gives you the criteria. The 24-hour recording, we expect a fall in blood pressure at night of about 10 to 20%, and we want the average pressures in these ranges. Now, global risk, as I said, I'm going to say very little about it, except I know you're all familiar with this, and others are going to expand on the topic. But the point I want to make is that over time, when we treat hypertension as a chronic high-risk disorder, things change. So we have to restage individuals and sometimes even change treatment if they've had a stroke, if they've developed coronary artery disease, if they've developed renal disease. Things happen, and so there's been so much emphasis on risk stratification at the baseline. But what I find is after 5, 10, 20 years of follow-up, things change and we have to restage their cardiovascular risk. And this particularly is relevant to the older patient, a geriatric patient. I'm going to come back to that point. Okay, better use of antihypertensive medications. There isn't time, and there wouldn't be in a 2-hour session, to completely review cardiovascular pharmacology of all the agents we now have. I think this summarizes in a very simplified way the ones we have as combinations and are using. And I would just say that these combinations tend to be the ones who are most used at this point, 2 or 3 of these drugs, and that a couple of points. Diuretics we are using generally in lower doses than in the past. We still see some hypokalemia, and I am fond of using the potassium-sparing agents such as amiloride or spironolactone with a thiazide-type diuretic. I'd just say I think we're all aware of the need to be cost-sensitive, but yet get the patients cared for, and with the growth of generic drugs in almost all the drug classes, this can be done relatively easily. We should know the adverse reactions, the ones that are real and the ones that are not. And I find that many patients believe that anything they take causes an adverse reaction, which makes this a bit of a problem for adherence that I'm going to come to in a little bit. And then this will come on to, in a few minutes, the J-curve, over-treating, which is now, unfortunately, a problem. We have made so much effort in treating that, in fact, we are over-treating some of these patients. Now, again, this is an outline, it's in the material, I hope, that you have, but I'd be glad to send you the PowerPoint if needed. But the point is that we have 4 basic strategies to lower blood pressure, and they each complement each other substantially. So if you use a diuretic, you sensitize the effect of the renin system, and so this combination is an excellent way to control blood pressure in most individuals. The same is true of calcium blockers combined with the renin system blockers. This is a very effective combination in many, many patients. Now, the upper right box here is where I think, less the future. These drugs, which were very helpful in the initial phases of hypertension control when we had very few to choose from, are leaving the scene. And I think if you ask yourself, would I like to take a centrally acting agent like clonidine if I didn't really have to, I think that you would agree that this is the box that should be diminishing in time, and the others are taking their place for most patients. Do we overtreat? And the answer is yes. In our enthusiasm to treat every hypertensive and lower the blood pressure as far as we possibly can, the risk tends to go up at lower levels of blood pressure in patients in this study with established coronary heart disease. This is taken from a publication by Dr. Messerly's group some years ago. It's based on a large trial called the INVEST trial. And in retrospective fashion, the investigators looked at the relationship of blood pressure on treatment to the age of the patient subgroup. And in the older age group, for both systolic and diastolic pressure, the curves go upward. There is a J curve. In other words, it's detrimental to lower blood pressure too much. Okay, I'm going to skip over this and go immediately to adherence because time is running out, although I started early, so I'm going to try to cheat a little bit. But this study, as published a few years ago, it's a summary diagram, almost a cartoon, of adherence to medication in hypertensive individuals. Starting out with everyone getting a prescription, the fall-off rate is almost 1/3, 25 to 30% over time, over less than half a year. And it's composed of 2 components. One is failure to refill prescriptions, which we now can track. through drug information systems, and those who fill their prescriptions and never take the drug. And this is now a newly recognized problem, so this is something we have to deal with. To finish on this point, there are those who take their medication only the day or two before they see you. These are the white coat, you might say, or masked hypertensives or white coat adherents. And when they leave the office, and they're out there for 2 or 3 months, they are taking less medication, consequently there's less control, and these comprise some of the masked hypertension group. Now, this 4-question questionnaire here was used by investigators to determine who is most likely to not be adherent to medication. And these are the 4 questions that were asked. And I'm beginning to employ this in my own practice, to start to ask these questions, because sometimes it's easy in a quick office visit to overlook that maybe a few questions can help you define the patient's adherence, and then address that through proper counseling. Okay, last slide. This is the future, I think, that might take place in the next 20 years. This is a kiosk. It is not a person. But we would only use such a thing if we already knew the patient. But patients go to drugstores, and in Canada, they can sit into this kiosk, have their blood pressure taken, get weighed, answer some questions. And that it would be wonderful if this information were available to us, that we could integrate that information with our office visit at a later time, or a phone call, or a computer message. So I think that this is part of the future. As I said, the hypertension care, preventive cardiology is leaving the office, it's migrating to the home, and we want to be assured that it's as effective as it can be. Thank you. Okay, I guess this is the quiz part. Now, are you all answering these? Is that what happens? Oh, okay. So then what happens? Oh, I have to read the question. Okay. During the past decade, which best describes changes in control of hypertension? A, control has decreased for diabetics but is unchanged for non-diabetics. B, control has decreased for all hypertensives. C, control has improved for all hypertensives. And D, control has increased only for diabetic hypertensives. So now what happens? They vote? Okay. Okay. C, control has improved. Well, you congratulate yourselves. You all get credit. For those of you that are skeptical, I'd be happy to send you my PowerPoint or the reference on this one. Okay, masked hypertension is defined as, I like this first answer, participating in a clinical trial without knowing the treatment. I guess I came up with that. I don't think I borrowed this from anybody else, so I'll take some credit. Clinic blood pressure is lower than home blood pressure. That's B. Clinic blood pressure is higher than home blood pressure. That's C. And clinic blood pressure is higher when standing compared to sitting. I guess. Go vote. Please vote. Oh, okay. B, yes. B is correct. Now, those of you who hit C, I would suggest you visit your ophthalmologist. I'm a little surprised, although, now some would say that in psychology, some would say this is a good question, and some would say it's not such a good question. But the issue is white coat versus masked hypertension, and masked hypertension is when the clinic blood pressure is lower than the home blood pressure, or out-of-office blood pressure. So I want to thank you for your attention. Okay.